Joining us now on the morning show from Henry Ford Jackson Hospital, emergency room physician, Dr. Ellen Lazzara. Good morning.
Morning. Hi. Good to see you guys.
Welcome back.
Hi. What's going on?
It's been 2 years.
Yeah, it has been. It has been.
You look the same.
Thanks.
A little more gray.
Yeah. A little stress in life, but it all abates in time.
Let me ask you first. How do you feel today compared to when this thing started?
Oh man, I remember the day that they canceled school. I remember going to Meyer that night, dropping the kids off at home, picking them up, and the daycare people were like, "Hey, they're canceling school, and we don't know when it's going to open up again." I said, "I got to go to Meyer and get some pasta," and I showed up with like the biggest shopping cart in the checkout area, and people were looking at me like I was crazy, and I felt a little crazy. I mean, I had a lot of camping food and stuff, but I was like, we better get some marshmallows for the kids too. But it was very anxiety producing in the beginning, I think, because the unknown is always strikes fear in people's hearts. And once you started seeing it leap continents and move across the world towards us, and it was initially kind of no big deal. We had not that many cases, and then once it hit New York, it was like, this is coming our way soon and fast. So and I think, so that was the first like kind of spike of anxiety, not knowing like how severe it was going to be, not knowing what the mortality rate would be. And then the next real stressful situation, so that was like 2 months or so. And then we started to run out of personal protective equipment. That was very stressful because I think I probably wore the same N95 mask for 3 weeks, and then eventually I transitioned to like a paint respirator that I had when I was in college, and could get the people. And the other thing too is like people would reach out. Like I called this local paint store in Ann Arbor, and the guy's like, "I don't have any N95s," and I explained why I needed them, and he's like, "I can get you some," and he called me and got me a bunch. And then the hospital stepped up too, in the local community, and we talked about people making those masks for us and the gowns, and that was super heartwarming, because then you felt like you had a shield of armor on for a while. But that was like, I'd say a really intense like 5-6 months. And then the vaccine was on the horizon, and that was very exciting. And so once I got vaccinated, it was the anxiety dropped a lot. And then also too, like, not to forget like how to treat the patients that were coming in. We didn't know how to treat patients. Initially, they were breathing so rapidly. They weren't breathing very rapidly, but their oxygen was very, very low. And so in that situation, we run to intubate somebody, and that turns out that that's not the best policy that was borne out with science and research. And so now we really have it dialed in on how to treat our COVID patients. But unfortunately, the virus is very strong, for lack of a better word. I mean, it's very virulent, and in certain patients, it's very fatal. And we're seeing, a definite drop. I don't think I've seen a COVID positive patient in 4 weeks.
That's gotta feel good.
It does. It feels great. We're seeing more flu now, I would say, than COVID. But still, the patients that we see are unvaccinated patients, have these kind of smoldering illnesses where it's high cholesterol, high blood pressure, kidney disease, diabetes, obesity, all these things that we treat with medication. You can live with for a long time. We manage this chronic illness, but it beats your immune system down in the long term, and that's what COVID takes advantage of. And so, seeing a 38-year-old get on a ventilator and not get off a ventilator and die is horrifying. It's terrible. But those are the general patients we're seeing now. The people who have and it's who we saw initially too. But the people that have these chronic medical illnesses. And of course, older patients too have more vulnerability. But I think there's a lot of lessons over the last 2 years. I think the planet and Earth and life is cyclical. This is going to happen again in like a decade, probably. Maybe not to the extent, but we had SARS in the early 2000s. We had MERS in like 2010, and then this happened now. So it's like hopefully it will be at least a decade before it comes back around again, or some variety of it. But I think being better prepared with stockpiles of masks and knowing the protocol, I think our generation will all go like, okay, put the mask back on. And I think wearing a mask in the department is going to be a pretty consistent thing during flu season at the very least for a long time. I think patients, I mean, we don't want people coughing on each other if we can help it, right?
Yeah, I don't want to be coughed on.
Nobody likes that. But I think better preparation, I think long term, I think people will take it seriously, but I think we'll also understand the lessons of, how to better handle the like the shutdowns and things like that. I think if people are able to wear masks and we have vaccines and we have more compliance with that, then things can stay more open and we don't have to make the streets empty. Because that was awful for everybody too. A lot of people said, is the cure worse than the disease? And I think there was a lot of harm that happened that was unseen.
We argued about that. You kind of argued about it daily at that time.
Yeah.
You weren't really sure.
Yeah.
But kudos to you and the staff, and just thinking about some. You probably had some new employees that started during the pandemic.
Oh, for sure.
I mean, just everything, and you're also trying to treat everyone else that's there for surgeries or heart attacks. It's amazing to think about it.
Yeah, when we shut down, we knew that there was a lot of the people who were having heart attacks weren't just going away; they were staying at home. We know that there were people that were staying at home with bad illnesses that should have come into the ER, and that's a very difficult balance to try and manage an epidemic, a pandemic, and then still have people who need to come to the ER to the ER. To the point we have a lot of new nurses. We had a lot of nurses transition to other sites and to work in other clinics. And I have an immense amount of admiration for our respiratory therapists, our nurses, our ICU nurses, the ER nurses, floor nurses, everybody, because they're hands-on with the patients. And I can literally look at a COVID patient from the doorway and tell whether or not they need to be intubated. But they're the ones that are administering all the medicines. They're in the room with them, literally like, a foot away from face to face and taking care of these poor people. So they're the angels, the workhorses. They're the ones that's doing most of the work. So
you actually lost colleagues.
I didn't personally have anybody in our department, but I know that there was a nurse or two at Henry Ford who did die from COVID. And we've had, transport techs or other nurses die from the flu. And it's a real rarity, but there's a lot of things to talk about whether or not to get vaccinated, and from my experience, I think that in reading all that I've read and listening to really intelligent people talk about this, I mean, there's no debate in my mind about getting vaccinated, and so, it's a shame when that happens because there's something that can prevent that. I mean, it's really run the gamut. We've had people, people say, "Are you vaccinated?" And they say, "Oh yeah," and I'm just like, "Good for you, that's great." People say, "I'm not vaccinated." I said, "We got to talk about that. We'll talk about that in like 5 minutes. Why are you here today?" Okay. I want to stop pulling my hair out because I'm worried about you.
Yeah.
I'm also like, I don't want to, we don't want to deal with this for another 2 years. Like, tell me why you don't want to get it. Well, I couldn't get it. My primary care doctor, this doctor told me I shouldn't get it, and that's not true.
Right.
But it's fine. Everybody's got their own reasons, but it's not a time in the ER. We have to establish rapport so quickly. Yeah. There's no time for criticism. There's just time for why and how can I help. Because you have a real opportunity because somebody they're in a really bad situation. Otherwise, they wouldn't be in the emergency department most of the time, and they're vulnerable, listening hopefully to what you have to say, there for your opinion, and just say, look, my grandparents got it, my whole family got it, all my colleagues got it, everybody's fine. Pregnant nurses got it, everybody's fine. What are you worried about? So,
Have you changed people's minds in that little conversation?
For sure, especially I think younger people who are not just not sure about like the whether or not they need to get it, and saying like, this week we've had to treat this many people in the department, and like you don't want to spread it to your grandmother. And I think because the motivation's not as big there because they don't feel like they're going to get really ill, and that can be a selfish decision, I think, in the long term, because nobody operates in a bubble. But I think we have a real opportunity, whether it's, somebody comes in camo gear and they're there for a heart attack, and I say, hey, do you wear a harness? Sure, great. Mm-hmm. Or a kid who comes in and broke his arm, is riding his bike, were you wearing a helmet? No, you really got to wear a helmet. Mm-hmm. I saw a kid last week who, had a really horrible head injury. There's a real opportunity, I think, to say something, and we should.
Yeah, that's great.
So,
how about all the things that people put on the back burner because they were afraid to come into the ER? I know there was a period of time where everyone was just staying away out of fear.
Yeah.
Has that improved?
Yeah, I would say the overall severity of illness that we're seeing is higher than normal. Our volumes are down, I think, by like 10 to 20% maybe. But the severity of illness is higher, and I think that's leads to aftershocks of people not engaging in care or not seeing their primary care doctors or not having access during these. It was particularly worse, months ago, but we're still seeing some of those after effects, like somebody who was supposed to get an EGD or a scope to look at their stomach, and they come in with a bleeding stomach ulcer. That's a perfect example. I've seen that a number of times. Why they weren't able to get it? Maybe we had nursing shortages. Maybe they didn't feel comfortable coming to the hospital. Maybe the appointments got backlogged for so long. There's a lot of reasons, but we're open 24 hours a day. Use your primary care doctor. We're for we're for the gaps in care. We're for emergencies, but also call your primary care doctor. There's a lot of preventative stuff that you can do to not be seeing me or a number of my colleagues. So.
We're still seeing overseas. In China's got a huge problem right now.
Yeah.
Is that anything that should concern us here?
I mean, I don't have, to be honest, I was so mired in keeping up to date with what was going on and for like a year, and then I kind of pulled back because it just wasn't good to bury my head in that for that long. And then, so I imagine yes, but I think this is a supposition on my point. I think that they were so strict with their lockdowns that not many people got COVID compared to here, that now they're getting exposed to a new variant, and it's more infectious. And so, and I don't know if they're using I don't know if they're using the same kind of vaccines over there or what their vaccine rate is. But yeah, I think infectious disease is always going to be with us. It's been with us since humans have been around. And, since we've been living with animals, cows, pigs, there's transmission of viruses from animals to humans. So it's always going to be with us. It's always going to be concerned. But staying healthy in general, getting sleep, you are what you eat, exercise, taking care of your body, not smoking, preventative things like wearing your seatbelt, all these small things that seem small, but in the long term, it will help us stay healthy as a population. And one of those things for infectious disease is obviously washing your hands and coughing into your elbow. I think everybody learned how to cough into your elbow. That's a big deal.
That has gotten a lot better.
That's a big thing. My kids, you're not allowed to cough into your hand. You will learn this early on.
Yeah, there has been some good things for kids' hygiene.
For sure.
Out of this.
Well, and so there has been some good things, but also on the other end, there's also some detriment too. So I think that we have to encourage, our kids not to be afraid of other human beings, right? Somebody sharing a drink with somebody else, or having a sneeze or a cough. Are you going to get COVID? I think that there's an anxiety problem that's yet to be revealed. That, when can I take my mask off? When can I gather and go to a rock concert? I mean, I went to a small concert a couple weeks ago, and I'm not gonna lie, I felt really uncomfortable for a while. So,
you get into these places where it's maybe mask optional, and kind of everyone just walks in and just looks around at each other. No one really has their own idea of what they're gonna do. Just play it by ear, and that's kind of how society is.
Yeah, I mean, you can't. Yes, we have a lot of freedom of choice, but we're all in the social contract that we decide that these are the general rules. You don't get to drive on the other side of the street because it's a danger to everybody else, right? So we have some limitations of freedom. It's not anarchy. And I think if there's things that make sense, like I'm going to wear a mask while there's a huge pandemic going on, that just makes sense. It doesn't cost me anything, But I think, some of these anxieties and fears that we're going to have to deal with the ramifications of in our our kids and getting back to normal. But you have to, right? Yeah. The kids need to be around other kids. They're so happy to be in school, so happy to be around their peers, and it just speaks to the social nature of human beings. Like, we need to be around in a community, but we can all do great things as a community too. So there's a lot of lessons.
The pandemic kind of put everything else on the back burner as far as public awareness on what's happening public health wise. Police, EMS used to tell me that #1 call was drug overdoses.
Sure.
That didn't change. You're still seeing that.
So it's so interesting you bring that up. So we just had a few meetings at the hospital, and I was on a phone call yesterday, and we were talking about how we're going to address, because let's not forget the last epidemic we were dealing with, which is the opioid epidemic in the United States, which has not gone away. And so there's been a big push to decrease the amount of opioids prescribed, which is the right thing, because the best way to prevent opioid addiction is to keep opioid naive patients naive and not give them.
Never have them.
Never have them. There's a reason and a time for, you break your leg, you break your arm, you're going to need some morphine, right, and I'm going to give that to you. Okay, so you have acute pain, but chronic pain treatment, there was a great study that came out of the University of Michigan where they surveyed surgeons in these post-operative patients and said, how many pain pills are you giving to this post-operative gallbladder patient or appendectomy? And it was all over the place. It was like, we give them 30 days, we give them 1 week, we give them 3 days or whatever. And so they just said, this is enough. This is what we recommend based off the research, this is what people need. And so that was a great paper that came out, and it really put some science behind what do people really need. And we know that pain control with alternating Tylenol and Motrin is very effective. Back to the initial discussion, opioids are still a big problem. We realized that Jackson had a tremendous opioid problem. A couple years ago, I would see maybe 2 overdoses a shift.
Wow.
Now I don't see as many, and for what reason, I'm not sure. Maybe we see a lot more methamphetamine use now than we used to, because people have transitioned. Opioids are harder to get, so now they're doing methamphetamines instead, which those stink as well. Those are not fun drugs to deal with, because they go from taking a nap and not breathing to being like wild and crazy and hard to control. So that's not a fun pathology to deal with in the department. But so prevention is a big deal, but on the other end, we look at this, there's a graph that I had during this meeting that shows the number of prescriptions going down, but the number of overdoses going up. And so, like, why would that happen? It happens because people can't get the pills. People with opioid use disorder can't get pills like they used to, and so then they're turning to street drugs like heroin. Heroin has been adulterated with fentanyl and carfentanil, because if you cut the heroin with a small amount of fentanyl, you make it more potent, you can sell more, make more money, and
kill people.
Yeah, for sure. It has an immense street value. I think something I read, like a kilo of fentanyl has like a $2 or $3 million street value. Like a kilo of gold is only worth like $40,000.
No, that's crazy.
It's crazy. Yeah, it's a crazy.
Wow.
Yeah, it's a lot. In order to deal with that, there's a lot of different options, and a lot of times when somebody comes in and they're withdrawing from heroin, we give them medicines to treat the symptoms. We give them anti-nausea medicine. We give them stomach cramping medicine to stop that. We give them some Ativan or something to help calm them down. But really, it doesn't meet the need that their brain chemistry is craving and needs, because they've become physically dependent and addicted. And so in order to treat that, there's another medication called Suboxone, or bupropion is the active ingredient. Suboxone is a trade name. And bupropion is a medication that helps not only slightly stimulate that opioid receptor, but also block it. So if somebody is trying to take more opioids, like Percocet or heroin, it won't go into the receptor because it's bound so strongly to that opioid receptor. And so you can turn somebody who was physically addicted and spending all day trying to get to try and avoid withdrawal, to try and meet those cravings and satisfy that brain chemistry, from somebody who's addicted to somebody who's dependent upon a medication that can be prescribed by a primary care doctor or an ER physician, and then you can get on a maintenance therapy, and you can maintain your therapy at home. You can get back to being with your family. You can be functional in society. You can reduce crime rates, et cetera. And it's been on the scene for probably, I don't know, like 20 years, but it has really gotten a lot more steam over the last 10, and it's an opportunity for our hospital system to meet the needs of this patient population. And it's a very lethal situation. If you come into the ER with an overdose, you have a 10% chance of dying that year.
Wow.
Yeah, and these are young people, you know,
right.
And you might not save everybody, but you could save, I don't know, how much is a human life worth, right?
Yeah.
To that mom or that child,
yeah.
or the big push, I think, for me personally in the next year is to try and work with a lot of really smart people. We have primary care clinics that are widely available, and we have very motivated physicians on our psychiatric team as well, some of which have been prescribing this medicine for a long time. We have a robust social work network as well, and reaching out to partners in the community like the Victory Clinic and other clinics to try and figure out how to best meet the needs of this patient population, because it's not going to go away. Mm-hmm. We're going to stop prescribing the opioids. People are still going to find a way, because their brain chemistry has changed, mm-hmm. and it takes a lot. And medical addiction therapy is, it's proven to reduce overdoses, proven to help people get to recovery. Abstinence is not. It just doesn't happen. It's kind of the similar argument that certain groups can make about sexual education. Just don't do it. Well, you can't just put your head in the sand. It's not going to happen. Human nature is human nature. People are going to seek the things that make them feel good, and so we might as well try and live with reality and say these patients have not gone away. These patients need more therapy. So
we appreciate all your time with us.
Sure.
Over these last couple of years, and all that you do to keep our community safe and healthy. Thanks for coming in.
Absolutely. Anytime.
Thank you.
From Henry Ford Jackson Hospital and the emergency department, emergency physician, Dr. Alan Lazzara.